Welcome. Thank you for having me lecture today. I'm going to be talking on one of my favorite topics, therapeutic drug monitoring in inflammatory bowel disease. These are my disclosures. What I will tell you is that I am a huge believer in therapeutic drug monitoring. That's probably my biggest potential conflict. So today we're going to touch on reactive therapeutic drug monitoring, really focus on proactive therapeutic drug monitoring, and then I'm going to introduce a new concept of reactive therapeutic drug monitoring. I'm going to warn you, I guess, that the slides will have a lot of words, and I did that purposefully. One, so you can go back and look through them again if you have any questions. And two, I really think words matter. And then we're going to point out why I really think that may have been holding back the field in general. So why is TDM so controversial? This is a question I get all the time. And I will tell you, I really wish I knew. It is not a question I can easily answer, although I think I may have found it out, at least what I think may be the answer in the last year or so. I think what's most important is really doing the best we can for all our patients, and that's really why we're here, and I think TDM is really an important part of this. So before we really get started, I want to be clear, therapeutic drug monitoring is really one part, albeit I think an important part of our changing treatment paradigms. Other people may say it a little bit more eloquently, but really what I tell my patients and tell physicians is these days we're really looking to treat smarter, earlier, deeper, to target, and more effectively. Simply, we really are trying to be able to predict who's going to have a more aggressive disease course, really focus on those patients, treat them earlier with effective therapy, look beyond clinical symptoms, look beyond just a steroid-free clinical remission, really pushing towards endoscopic and biochemical improvement, if not remission, treating to target, making sure you hit whatever goal you want to with your patients, and then treating more effectively, which is what today's lecture on, which is proactive therapeutic drug monitoring. For those of you who know me, you'll see, although that's not me, that is really how I practice and how I am. I really try to keep it simple, honest, and real. So do we need TDM for all biologics? I think this slide will be a good intro and even summary for the entire lecture. Short answer is no, but please feel free to do them if you wish. I really recommend it for anti-TNF therapies. There really is less data for our more novel therapeutics, and those are actually less immunogenic. The anti-TNFs are by far the most immunogenic of the agents we have. I recommend reactive therapeutic drug monitoring for primary and secondary loss of response for anti-TNF therapy. We'll go into why. This is important. Please don't give up on adalimumab or infliximab until you have drug concentrations of at least 10 to 15 micrograms per milliliter. Why is that important? It's important because if you give up on either one of those agents, you're saying that really it is a failure of the drug class and you're giving up on the entire class. I recommend proactive therapeutic drug monitoring following induction and at least once during maintenance. Post-induction, we're looking for infliximab concentrations of greater than 7 to 10 and adalimumab concentrations greater than 8 to 12. You'll see that targets during maintenance are not too dissimilar, but greater than 5 to 10 for infliximab and greater than 8 to 12 for adalimumab. It's not really just me recommending this. A lot of these come from a consensus statement that I was part of here. I highly recommend it. Maybe a little bit biased, but I think it's a good overall review. And of therapeutic drug monitoring. It has really some nice tables. You can see it referenced there below. So unfortunately, although anti-TNF and other biologics have really revolutionized the treatment of inflammatory bowel disease, you can see here there really is a high primary non-response and secondary loss of response. You can see on the left, really the rate of primary non-response is upwards of over 1/3 of the patients. And on the right, even within the first year, almost 40% of patients will lose response to anti-TNF therapy. There was a really nice follow-up of a prospective study done in the UK called the PANTS study, which showed that after 3 years, 2 out of 3 patients will lose response to adalimumab or infliximab. And really, it's that week 14 drug concentration that predicts long-term response and remission. Although we have a lot of agents now, I still think it's critical to really optimize our anti-TNF therapies. They really still are the best agents for some of our sickest population, including our patients with perianal Crohn's disease. So I'm going to take you back to a simpler time. I certainly had a lot more hair. I'm not sure if you can see it, but it was less gray at the time. Infliximab was approved now just over 25 years ago. It was actually approved as episodic therapy. The patient would get the drug, you would wait for them to lose response, and then you'd give them another dose. So it was a great way to treat if you wanted patients to develop antibodies against the drug, right? Intermittent exposure to an antigen primes the immune response. And this is exactly what happened. This is from a nice study in the New England Journal out of Belgium. They showed that 60% of patients, actually more than 60% of patients who were given episodic therapy developed antibodies to infliximab. This, not surprisingly, was associated with a higher risk of infusion reactions and a much shorter duration of response. It took almost 5 years for us to really show that an induction regimen and a maintenance regimen improved outcomes and decreased immunogenicity. Took over 10 years to really show that combination therapy with azathioprine was more effective than infliximab or azathioprine alone in a very specific population of patients that were bio-naive and azathioprine-naive active Crohn's disease. My study came out 10 years ago now, where we first showed that proactive therapeutic drug monitoring and dose optimization resulted in a longer duration of response to infliximab and less drug discontinuation than standard of care. So what is reactive therapeutic drug monitoring? It is the measurement of drug concentration and antibody levels in the setting of primary non-response or secondary loss of response to a biologic agent. The goal of reactive therapeutic drug monitoring is really to inform about reasons for loss or lack of response and to facilitate therapeutic decision making. Why? It rationalizes and better directs the management of primary and secondary loss of response to biologics. It really tells you who is going to benefit from more drug, such as someone with low drug concentrations and no or low anti-drug antibodies, and someone who just needs to move on to another agent, someone with absolutely adequate drug concentrations, or sadly, more commonly, someone who has high-level anti-drug antibodies. Many studies have shown that reactive TDM is associated with better therapeutic outcomes compared to empiric anti-TNF optimization, which is thought of as in the past standard of care. And it is more cost-effective than empiric anti-TNF therapy optimization. My whole thing is really why wait for a patient to lose response? It doesn't particularly make sense to me. If you talk to any of your colleagues, or if you do liver transplantation, I guarantee you are not waiting for a patient to reject their liver before taking a tacrolimus level. You think back to when we were trainees, we would use vancomycin and gentamicin for the treatment of sepsis. And certainly we weren't waiting to check if levels were adequate before a patient ended up in the intensive care unit. With some agents, high drug concentrations are associated with toxicity. That's not necessarily the case with our biologics, but more importantly, with biologics, they're immunogenic, and low drug concentrations can lead to antibody development and loss of response, as I've showed you. In fact, to me, not doing therapeutic drug monitoring, not making sure you have adequate drug concentrations at trough is akin to episodic treatment, which we know is not particularly effective. Definition of proactive therapeutic drug monitoring is the measurement of trough concentration and antibody levels with the goal of optimizing your biologic therapy to achieve a threshold drug concentration. The goal is to improve response rate and prevent secondary loss of response as well as immunogenicity. Why do we do this? It's been associated with better therapeutic outcomes compared to empiric optimization and/or reactive therapy or reactive therapeutic drug monitoring using anti-TNF therapy. There are some safety considerations. There's what we'll touch on, which is optimized monotherapy instead of using combination therapy with an immunomodulator, which we know may be associated with a slightly higher risk of serious and opportunistic infection, as well as lymphoma. And there's the concept of infliximab de-escalation or discontinuation, and discontinuation of an immunomodulator when a patient is in clinical remission. So what is the evidence for proactive therapeutic drug monitoring with anti-TNF? We showed again 10 years ago that proactive therapeutic drug monitoring prolongs the duration of infliximab with less drug discontinuation and less loss of response. Later on, we showed very similar findings with adalimumab. Looking deeper with the University of Pennsylvania, we actually showed that proactive TDM with infliximab decreased IBD-related hospitalizations and surgeries, decreased serious infusion reactions and antibodies to infliximab, and of course decreased the risk of treatment failure when compared to reactive therapeutic drug monitoring. We also showed that proactive TDM following reactive TDM improved outcomes, and this makes sense. If you have a low drug concentration, you dose escalate, you want to make sure that now you are in the therapeutic range and above a therapeutic threshold. It's not just retrospective studies. There are multiple prospective studies demonstrating the effectiveness of therapeutic drug monitoring. Here are 4 of them. The first one I'm sure you have heard of, it's called the TAXIT trial. And although it missed its primary endpoint due to study design, as all patients were dose optimized initially, it did hit 4 secondary endpoints, including decreasing the need for rescue therapy. Most importantly, when people were given a one-time dose escalation with Crohn's disease in those patients that needed more drug, this put more people from a clinical response into clinical remission and decreased CRP. Also important was that this was cost effective. In our study and in TAXIT, between 25% and 33% of patients actually dose de-escalated. PALOT is a nice Israeli study, pediatric Crohn's disease. They compared proactive versus reactive therapeutic drug monitoring in patients on adalimumab after induction who had a clinical response. And when they looked at these groups out after a year, what they found is the group that had proactive therapeutic drug monitoring had increased sustained clinical and biochemical remission compared to those patients that just got reactive drug monitoring. Taking it even outside the field of IBD, NORDRUM B looked at 450 patients with multiple immune-mediated inflammatory disorders, including ulcerative colitis and Crohn's disease. And they showed that during maintenance therapy, proactive TDM led to higher rates of sustained disease control when compared to the standard of care. And the delta in this group was about 20%. Precision was a newer study. They looked at patients with IBD in remission, and they used a PK dashboard, sort of aiming for trough concentrations of 3, which I would argue is very low. And they compared that to standard of care, and they showed that even when aiming for a drug concentration of 3 with infliximab, the group that got proactive TDM had longer times between relapse, higher rates of clinical remission, and higher rates of clinical remission plus normalization of fecal calprotectin. And I'll point out that that was despite 3 patients whose fistula opened up with dose de-escalation to get them to a level of 3. Probably would have looked, actually definitely would have looked even better if they had used higher concentrations. Although most of the data for proactive TDM is during the maintenance phase, as I showed you, it's probably even more important during the induction phase, right? This is when your patients are the sickest. This is when they have the highest clearance. CRP is elevated, fecal calprotectin is at its highest, and albumin is at its lowest. There was a nice prospective study done by Marla Dubinsky at Mount Sinai, and they really looked at patients, again, using a PK dashboard here. The aim was to get an infliximab concentration of 17 micrograms per milliliter at the 3rd dose of infliximab and 10 micrograms per milliliter prior to the 4th dose of infliximab. Not surprisingly, I would argue, they demonstrated that over 70% of patients were forecasted to require accelerated induction dosing. When these patients were compliant with what the PK dashboard recommended, this increased durability and reduced immunogenicity to infliximab. There was a pediatric study out of Vancouver and Glasgow that actually looked at using treat to target in addition to proactive therapeutic drug monitoring during induction. And they showed that this resulted in higher post-induction trough concentrations and greater long-term corticosteroid-free clinical and biochemical remission. There have been multiple modeling studies suggesting, particularly in pediatrics, that pediatric patients require greater amounts of infliximab than the standard dosing. This is a recent one out of Belgium that showed that most patients required higher dosing, and the outcomes for pediatric IBD patients was better with accelerated dosing. What else can we talk about? We can talk about optimized monotherapy with anti-TNF. We know, at least according to Sonic, in that patient population of active Crohn's disease, bio-naive, immunomodulator naive, that those patients did better with combination therapy compared to infliximab alone compared to azathioprine. However, I'll point out that a reanalysis, a post hoc analysis of this study done by Steve Hanauer and Jean-Fred Colombel, what they showed is when they broke it down into quartiles, they demonstrated that it was really the infliximab concentration that mattered, not whether the patients were on a concomitant immunomodulator. So patients in the lowest quartile did the worst, and patients in the higher quartiles did better. There was another nice study done out of Belgium that really compared optimized infliximab monotherapy to combination therapy. And they really showed that it was as effective. Drug retention rates at 1 year were similar between 65 and 75%. There was no difference in the use of corticosteroids or mucosal healing. Again, I'll point out that most patients treated are not on combination therapy. They're really on monotherapy. So I would behoove you to really optimize this if you have patients on monotherapy. What about stopping a concomitant immunomodulator? The data we have on combination therapy really goes out to about a year, particularly in the SONIC trial. Afterwards, most patients are asking to stop an immunomodulator, and most clinicians are recommending that it be stopped. Really, before you stop an immunomodulator, you want to make sure the patients have enough anti-TNF on board. So check a drug concentration and know that when you stop an immunomodulator, this drug concentration may fall. So I would actually argue you should check a post-infliximab or adalimumab concentration after stopping an immunomodulator. Again, a study out of Belgium showed that at the time of stopping an immunomodulator, detectable trough concentrations were associated with long-term response, and those patients with infliximab trough concentrations greater than 5 did even better. Although there were no outcome differences at 1 year, stopping an immunomodulator led to lower infliximab concentrations and higher CRP, which I would argue will lead to long-term risk of flare. There was a meta-analysis. There were actually 2. I'm showing you this one because it was positive. They looked at 26 studies. 9 of these were randomized controlled trials. And what they found is that proactive TDM is better than standard of care with regards to treatment failure. And if you even look at hospitalization, it was borderline for decreasing the need for hospitalization. Proactive TDM, they found, was better than reactive TDM as far as treatment failure is concerned. And here they hit for decreasing the need for hospitalization with proactive therapeutic drug monitoring. So again, I'll ask you, why is TDM so controversial? I really think it comes down to semantics, and this really came to me probably within the last year. I think there's been a misunderstanding of proactive therapeutic drug monitoring. As I mentioned, the goal of proactive TDM is to optimize anti-TNF drug concentrations above a threshold. This can be during induction, post-induction, and or maintenance therapy. And this is regardless of clinical, endoscopic, or biochemical activity. I think there's this incorrect belief that proactive TDM only refers to optimization of drug concentration for patients in remission and often thought of as only during maintenance therapy. I've also found that there's this changing definition of reactive therapeutic drug monitoring, and I really learned this when having a discussion, I'll call it. It was more of an argument with one of the other people who is not so proactive TDM. The classic definition really is the measurement of drug concentration and antibody levels in the setting of primary non-response or secondary loss of response to a biologic agent. This has really been based on clinical symptoms. and then using objective measures to confirm that this is an active IBD flare. I've seen a newer definition, or at least how people tend to think about this, is that reactive TDM is measurement of drug concentration and antibody levels in patients with ongoing inflammatory markers or ongoing endoscopic disease despite clinical remission. Even checking these more objective markers early. And this is based on treat to target and newer treatment goals that I sort of touched on at the beginning. If you really look at this, proactive TDM, as I define, and the newer definition of reactive TDM really lead to the same outcomes. Dose optimizing the biologic agent to achieve better drug concentrations and better outcomes. So really what I'm trying to do now is really get people to sort of come together. I don't think we're seeing this with our government or our politics, but I'm not going to step on that third rail right now. But I will try to get us to come together as far as therapeutic drug monitoring is concerned. And that's why we published and I introduced at this past DDW the concept of preactive TDM, really incorporating therapeutic drug monitoring as a part of treat to target. The definition here is measurement and optimization of drug concentrations in addition to utilizing objective measures of disease activity with the goal of attaining clinical, biochemical, and endoscopic remission. This is ideally starting during induction or post-induction, ideally using model-informed precision dosing or a PK dashboard. And I think targets may change in the future, particularly considering transmural healing in patients with Crohn's disease. The goal is to improve remission rates, prevent secondary loss of response, and attain better and deeper outcomes for our patients with inflammatory bowel disease. I'm hoping preactive TDM is more understandable and less stigmatizing. And I really hope that this will improve outcomes for our patients with inflammatory bowel disease. So in conclusion, and I add a little bit more to the conclusion because you will be able to keep or download these slides or take pictures as you so choose. I'm going to show you two slides really of our consensus statement on therapeutic drug monitoring. This is on reactive TDM. And I point out again, this really should be done for patients with primary or secondary loss of response. In this consensus statement, we actually said it would be for all biologics. As I mentioned, I think it's most important for anti-TNFs, and particularly with those anti-TNF therapies, please, for adalimumab and infliximab, don't give up on this drug until you've attained drug concentrations of greater than 10 to 15. And this is probably more for patients with more complicated disease, such as perianal disease. For proactive therapeutic drug monitoring, we recommended if after induction and at least once during the maintenance phase, after reactive therapeutic drug monitoring, when considering combination therapy with an immunomodulator, in certain patients, you can consider optimized monotherapy as an alternative to combination therapy. And certainly, if a patient is just on infliximab, it is certainly better to use proactive TDM and dose optimization compared to unoptimized monotherapy. We talked about when potentially de-escalating infliximab or stopping an immunomodulator. It should be done both before and after. And I have patients come to me, new patients on infliximab, 10 mg per kg every 4 weeks with greater than assay infliximab concentrations, and I absolutely dose de-escalate these patients. It's most important in patients with more severely active disease and those with higher drug concentrations, which is why I think it's very important during the induction phase. At this time, we really suggested prior to doing this for other biologics other than anti-TNFs, we need a little bit more data. Hopefully you'll like this slide. This is optimal drug concentrations. And again, you can see here the focus is really on infliximab and adalimumab, though I do touch on the other anti-TNFs and at least two of our more novel agents. And you can see here, really focus on the consensus statement from the AGA. I do point out what I do in remission, certainly for both proactive as well as reactive therapeutic drug monitoring. Again, in most of these cross-sectional studies, the higher the drug concentration typically is associated with the better and the more deep outcomes. Here's the reactive testing algorithm. Here I'll point out, important if patient has symptoms, it's not just enough to have symptoms, you really need to confirm with objective measures of activity that they're having a secondary loss of response. If the therapeutic drug concentration greater than 10 to 15 with adalimumab or infliximab, then you're going to change drug class or potentially patient may need surgery. If they have subtherapeutic drug concentrations, which I would argue is the majority of the cases, no anti-drug antibodies, easy, dose escalate these patients. You get more bang for your buck by shortening the interval than you do by increasing the dose. If they have anti-drug antibodies, now it comes down to are these low-level or high-level antibodies. Low-level, I dose optimize these patients, I shorten the interval, potentially increase the dose, and in some cases, I add an immunomodulator, at least temporarily. If they have high-level anti-drug antibodies, I typically will switch within class if possible. You know they responded typically to an anti-TNF. Now they lost response, but it's because they had low drug concentrations and now have high-level antibodies. You know greater than 90% of these patients are going to respond to another anti-TNF. Importantly, these patients are more likely to develop antibodies to a second anti-TNF, so please have them on a concomitant immunomodulator and or do proactive therapeutic drug monitoring. Certainly you can switch without class, but they're no more likely to respond to another agent than they were initially. You know, you're looking maybe 2 out of 3 patients will have some sort of response. Be careful with some of the assays, how they measure anti-drug antibodies really have not been validated, and I find people often get confused what is high level and what is really not high level. If you have any questions, seriously, feel free to reach out to me. Here is the proactive therapeutic drug monitoring algorithm. Again, I typically aim in the middle for concentrations of 5 to 15. If greater than, I will talk to them about dose de-escalation and de-escalate. And similar here, I will optimize them if they have low drug concentrations. Shortening the interval is more effective than increasing the drug. The PK is better. I introduced the concept of preactive TDM. You may recognize some of the people in this picture. I really am hoping to get everybody together and on board with using TDM in conjunction with our treat to target mentality to improve the quality of life and improve outcomes with our patients with IBD. And a special shout out to Kostas Papamichael right there in the middle while we were on Boston Garden Court. And you can see there on the left, actually, I guess facing it on the left is one of my sons, and on the right is our IBD fellow. But again, special shout out to Kostas, who probably knows more about TDM than anybody in the world. Thank you. Feel free, reach out if you have any questions, and I hope you enjoy the rest of the course.